Hey everyone, so we're going to be talking about our next lecture, which is over range of motion. Now with range of motion, it's defined as the amount of motion that occurs between two bones. So range of motion is determined by the structure of the joints and the flexibility of the soft tissue that crosses that joint. So with normal range of motion, it'll vary based upon age and gender and body type, and if it's performed either passively or actively. So some other factors that will include is the integrity and flexibility of the periarticular soft tissues. And, range of motion is a basic technique, and it's used for the examination of movement and for initiating movement into a program of therapeutic intervention. And I also have the definition for functional excursion on here. So if you remember back to 101, the distance of a muscle is capable of shortening after it's been elongated to its maximum. So, like I said, it's range of motion is a basic technique. You're going to be definitely during the physical therapist initial evaluation and the examination of movement, no matter if it's a shoulder or a hip or a knee. They're looking to see how much active range of motion, and then also comparing that to when they, as the therapist, does passive range of motion. And then we'll get those initial measurements, baseline measurements, and include that in the evaluation. So when we talk about all these different terminologies that are on here too, we're going to have, like I said, we'll talk about active and passive insufficiency here in the next couple of slides too. So for active insufficiency, if you remember, we talked about it before, and for passive insufficiency, this is only going to be for those two joint muscles, so not one joint muscle. So only ones, the muscles that cross two different joints, okay? So active insufficiency is a point where a muscle can shorten no more in that position. So for an example would be maybe the biceps brachii or the hamstring curl and prone. So like if you were to do bicep flexion and then do full shoulder flexion, then that is going to shorten that biceps brachii as shortened as it can get, okay? Same thing with the hamstring curl prone, especially if you did prone and hip extension and doing knee flexion in a combination of movement, that is going to put that hamstring curl actively insufficient. So you're just trying to get in that muscle as shortened as possible over those two joints. Passive insufficiency is the opposite. So this is the maximum elongation of a muscle. And a lot of times you'll see this when we do like in 150, we're pretty much putting those muscles in passive insufficiency when we do muscle length testing. So like for instance, like how you did testing the biceps brachii, you did full shoulder extension and elbow extension, and you are elongating that muscle as possible over those two joints. So, muscle function is best at mid-range where the ideal length-tension relationship exists, especially for those multiple joint muscles. So remember Goldilocks and the Three Bears, we talked about that to where, we want the motion just right. So you don't want to be kicking a soccer ball and having the movement all the way in active insufficiency or into passive insufficiency, because that does not put the muscle at the optimal length for performance. So, why should passive insufficiency be promoted for like the hand and wrist extensors in a patient with quadriparesis? So, by putting the wrist and passive insufficiency, then they could maybe handle a spoon, right? Putting it into to where if you do wrist extension, then the fingers are automatically going to flex, and they could do holding a hairbrush, different things that you can perform. The other, that would be, and then some other things too is patients who have suffered a spinal cord injury, they rely on passive insufficiency of the extrinsic finger and wrist flexion muscles to perform a gross grasp. So that would be the wrist tenodesis. Okay, so make for sure you look over those. So there's so many different contractures that are involved that were already mentioned in stretching. So I definitely want you to make for sure you look over each one of those terminologies. I'm not going to go over them again, but just being able to show with that limitation, because they're going to go hand in hand with these different contractures of the limitations of joint range of motion. And then when we get into impairments, so pathologically joint range of motion may be due to a disease, an injury, immobilization. Maybe they've been in a cast or a brace for a really long time, or even a shoulder sling, or even overuse and aging. Now for hypermobility, this is excessive motion beyond the physiological motion expected, and it can be caused by an inability of a bone or soft tissue to limit the motion. And, hypermobile joints are not necessarily pathological, but they are more susceptible to injury and pain because there's an increased tensile and shear forces. So with this, usually treated by joint protection. Now, obviously, for the hypermobility patients, we don't need to make them more mobile, right? So if anything, they need more joint stability. So we would focus more on strengthening that shoulder capsule and the different muscles surrounding that joint. We'll talk about more clinical scenarios, definitely in lab, but just know that laxity and instability for hypermobility joints will increase injury risk. But they're also, for the elderly adult, they can have more increased risk of degenerative joint changes and have abnormal motion across the articular surfaces. Now, the patients that need range of motion are going to be the hypomobility patients. So they're going to have limited motion from physiological motion to be expected. And it could be caused by several different things. It could be a bony or cartilaginous block. Now, if it's a bony block, we were not going to be performing passive range of motion, active assisted range of motion, because a lot of times that bony block could be a fracture. And so if that is an abnormal infield with passive range of motion, then what it should be, it's going to feel like bone on bone, right? And so then therefore, you need to talk to your PT and see about additional imaging to be done. Now, maybe the hypomobility is because of inability of soft tissues to elongate sufficiently. So if it's a muscle, maybe the muscles need stretched. And then also maybe the joint capsule is limiting. So you're going to know that with the infill, and maybe that patient needs joint mobility, joint mobs. And then also the ligaments and tendon, which is going to be really hard to even tell. It's going to go hand in hand if the muscle is tightened, but a lot of times with the ligaments and tendons, you're going to see them pop out more if they look really tight. Obviously with this hypomobility, they're going to be limited in active or passive and or both. And so typically, when you want to do, if someone is limited in range of motion, maybe you tell them, let's do shoulder flexion, and they can only bring it up maybe to 90 degrees in range of motion. And then you look back to the initial evaluation, passive range of motion, they were able to get to 115. Now that a lot of times, obviously the joint is able to do more range of motion with passive range of motion compared to active range of motion because of muscle weakness. Now, if let's say you have a patient and you do passive range of motion and it's only to 90 degrees, and active range of motion is only to 90 degrees, then that, yes, muscle weakness is probably definitely there, but it's not because of the limited range. It's more likely because of muscle tightness or, ligament and tendon or the joint capsule being tight. And you'll know that the difference with the infield. And also is, looking at those two joint muscles and doing muscle length tension to see what could be the cause of that. Some other reasons why you want to do passive range of motion first is because maybe they are post-op patient, and that is only what they're allowed to do at the moment is passive range of motion, where the therapist performs, maybe shoulder flexion or abduction to limited range of motion. But, if your patient still, let's say they progress later on and, or maybe they're not a post-op procedure, you're still going to do passive range of motion, even if you're doing active assisted active range of motion until you regain that full or functional range of motion as possible. Some other reasons too is because maybe actively it's too painful for them to perform the motion. Maybe they're having muscle spasms or muscle guarding because of the pain. And, that maybe that would be a better reason to do passive range of motion until you're able to perform some pain control. So, joint infills, I've already kind of talked about already, but why are they so important? And, it definitely gives us the PTA's information that we need about the joint integrity. Is it a normal? Is it supposed to, or is it now, maybe it was a firm feel and now it's more of a hard end feel. That could be bony fragments in the joint or joint capsule. Some other things is knowing the differences with those different joint contractures that, like that were previously mentioned, to see what could be the cause of that and how can we make that range of motion improved. So, there's different factors that lead to decreased range of motion. So a systemic disease would be like RA, rheumatoid arthritis, could be lead to that decreased range of motion. Joint diseases such as osteoarthritis and frozen shoulder. Neurologically, like from a spinal cord injury, cerebral vascular accident, traumatic brain injury, maybe they have a muscular disease, surgical insult, trauma, maybe inactivity. Maybe they were in a coma for a long period of time and now they have limitations in range of motion. But, just know, even with that, with patients that are incoherent, a lot of times us therapists will still do passive range of motion and to maintain that joint range of motion. So that way, hopefully one day when they are more coherent or they come out of that coma, they're not going to have those joint contractures, okay? And also it helps with skin integrity. Immobilizations would be maybe they're, after they get the cast removed or after a surgery, a lot of times too, maybe like a shoulder surgery, let's say a rotator cuff repair, maybe they're supposed to be in that sling for a period of time, and hopefully they'll see therapy at the time frame for the protocol. But I've had patients to where it's been extended and they've been in that sling for so long, and then now they have more immobilization of that joint. So for the therapeutic goal of range of motion is to maintain existing joint and soft tissue mobility and to minimize the effects of contracture formation. So, necessarily we don't increase with range of motion, but we maintain, with that, it could be a little bit confusing because we want to definitely improve range of motion, right? For those effects, but just knowing with maintaining with contractures, it's different because maybe we got as much range of motion as we could. Maybe they don't have full elbow extension, but they have functional range of motion. Okay, so in that circumstance, maybe we're not able to get full range of motion, but we try to maintain that range of motion without making it worse and having more of a contracture. All right, so let's get some more in these terminologies now that we've talked a little bit about for each one. So passive range of motion is defined as movement of a segment within the unrestricted range of motion that is produced entirely by an external force. That would be you as a PTA or a PT. There's little to no voluntary muscle contraction, so we want our patient to be relaxed and to not have muscle contraction is what we really want. and constantly reminding them to relax. So, as the PTA, you will perform gravity, or well, it says external force, sorry. The external force may be from gravity, a machine, or another individual, or another part of the individual's own body. So, a machine would be like the continuous passive motion, like the CPM machines that maybe you have seen for like a total knee replacement. So that would be a passive range of motion device. Another is, it says, or another part of the individual's own body. So like you could do, for shoulder flexion, sorry, my little picture here. And, you can take the other hand to guide it into passive range of motion. But a lot of times patients have a hard time doing that and being relaxed, in the supine position. So it's a little bit more challenging, that's for sure. But, just know that passive range of motion and passive stretching are not the same thing. They're not synonymous, because stretching is what you're going to hold for a longer period of time, and passive range of motion, you're just doing gentle range of motion and not holding. Okay, so that's the difference between the two. But a lot of times when I do passive range of motion with a patient, I'll incorporate periods of prolonged stretching as well. So I'll kind of go back and forth between the two. All right, next I'm going to talk about active assisted range of motion, because that would be the correct order. It would be passive range, active assisted range of motion, and then active range of motion. So active assisted range of motion, as by definition, is a type of active range of motion in which assistance is provided manually or mechanically by an outside force because the prime mover muscles need assistance to complete the motion. So obviously you can perform active assisted range of motion on your patient. Your patient can progress to doing exercises that we'll talk about to where it will assist the range of motion, like let's say a table slide, right? You're sliding on the table with a towel. That towel is helping with that range of motion and that mobility, so that would be an active assisted range of motion exercise. It says mechanically, so that could be even that continuous passive motion, and you can incorporate active assisted range of motion with that as well. And then talk about active range of motion. So is movement of a segment within the unrestricted range of motion that is produced by active contraction of the muscles crossing that joint. So this is when, maybe you progress your patient to where now you're like, okay, let's just do active range of motion of the shoulder into flexion. They're just moving it on their own. And you can, with any of these, especially when it comes to active assisted, well, more active range of motion, you can use gravity as your friend to put them in a gravity minimized position first before going against gravity. So there's different ways that you can progress your patient with that. And just to talk a bit more too, well, we'll talk more about passive range of motion, I guess, in just a second. All right, so for passive range of motion too, obviously no active or voluntary movement of the patient, usually slightly greater than active range of motion. So because of, maybe because of muscle weakness and they're not able to have that full range of motion to the passive range of motion point, or because of pain. So there's different factors with that. So usually though, passive range of motion is typically a little bit greater than active range of motion unless they have full functional, full active range of motion, then they're going to line up. Some other indications too with that. So for passive range, so in the region where there's acute inflamed tissue, passive range of motion is definitely going to be beneficial. Active motion would be detrimental to the healing process, and inflammation after injury or surgery usually lasts 2 to 6 days. So each protocol is going to be completely different to make for sure that you support the joint that was postoperatively treated, because you don't want to interfere with the healing process. Another indication would be a patient's not able to or not supposed to actively move a segment of the body. Maybe they're in a coma, maybe they're paralyzed or complete bed rest, and movement is provided by an external source. And then passive range of motion is indicated after surgical repair of contractile tissue when active range of motion would compromise the repaired muscle. So kind of the same thing I already talked about. So there's several different goals. So those are all the different ones. Let's see, from that. I feel like I talked a lot about that already, but let's talk about this one too. So for goals for passive range of motion, the primary goal for passive range is to decrease the complications that would occur with immobilization. That would be such as cartilage degeneration, adhesion, contracture formation, sluggish circulation. Specifically, the goals are to maintain joint and connective tissue mobility, minimize the effects of the formation of contractures, maintain mechanical elasticity of muscles, assist circulation and vascular dynamics, enhance synovial movement for cartilage nutrition and diffusion of materials in the joint, decrease or inhibit pain, and assist with the healing process after injury or surgery, and help maintain the patient's awareness and movement. So there's several different, uses. There's also limitations involved. And so true passive relaxed range of motion may be difficult to obtain because when the muscle is innervated and the patient is conscious. So passive motion does not prevent muscle atrophy, it does not increase strength or endurance, and it does not assist circulation to the extent that active voluntary muscle contraction does. So there's several indications, obviously if active range of motion is contraindicated or painful, and, indicating of and teaching active exercises, warm up for stretching exercises. So there's different indications that are listed in your textbook too, so make for sure to look over those. And also precautions, very important. But obviously if it's going to interfere with the healing process, or not, you got to be aware that you can alter the healing process. But looking for signs of inflammation, what that looks like. Precautions would be, if they're hypermobility, you do not want to go beyond the normal range of motion. So they really wouldn't be a candidate for that, for passive range. Maintenance of compensatory functions. So maybe they need some limitations of that range of motion so that way they can maintain an upright position, especially for like a spinal cord injury, or even using that wrist, for different wrist movements for grasping. So maybe we don't want to interfere with that. Some other precautions would be like if someone has severe osteoporosis or osteogenesis imperfecta, if they have impingement syndrome, so that could be at the shoulder typically, and you should review and know what muscles that would be involved. We'll talk about that more when we get into the shoulder. Spasticity, central nervous system, and loss of normal sensation proprioception. So maybe they don't have, the right sensations to say, oh, this is what pain is occurring, okay? So make sure you're aware of all those precautions. So some different things to be aware of, especially if it's an acute injury, okay? You definitely want to make for sure, passive range of motion would be contraindicated if the pain produced before joint limitation. So when you're performing passive range of motion, you want to make for sure, you ask them like, okay, take a deep breath and work on those relaxation techniques and let me know. I'm going to take your shoulder, shoulder is easy because I'm in the video, but I'm going to take your shoulder into as much range of motion as you can tolerate. And when you experience sharp pain, let me know. Okay, and we're going to go before that sharp pain. So it's okay. Maybe they came into therapy with a 5 out of 10 pain. So as long as we're not trying to increase that pain. And, probably the differences, especially for the shoulder, is going to be that adhesive capsulitis. Now, not doing so progressive anymore is what they say, but, you want to avoid that increased sharp pain because you're kind of going to increase that inflammation. It's going to make things more irritable. You're not going to get that range of motion. If pain is produced at limitation, or if pain's produced after limitation, and be cautious with patients who cannot express pain, if they're in a coma. So make for sure that you take extra caution with those types of patients. So next we're going to be talking about all the different techniques involved with passive range of motion, which we'll go over a lot during lab anyways. But You want to prepare the environment, so that just means getting all the supplies that you need, anything that you need to do to make your patient comfortable, either that be pillows or blankets or sheets or anything, and draping properly. You're gonna see this draping more so properly if, you know, especially if they're a post-op procedure, they're going to want some pillows. They're going to want to be in a really comfortable position. You're going to need to know how to take off a sling or take off a brace properly, more likely in the supine position, so that way it's more comfortable for them. Or you might be having to drape, like in the hospital setting. Let's say it's a lower extremity, so you need to make for sure, especially if they just have a hospital gown on, you need to be able to drape with the sheets correctly, so then that way they can stay modest. So what are you going to do? So you're going to definitely use proper body mechanics, and you're going to move joints through the combined movements or individual movements if limited in a direction. You definitely want to move very smoothly and slowly, pausing and starting and stop, and pausing, and if you need to start or stop positions. So really paying attention to your patient, of their symptoms. Facial grimaces is a really good indicator that you're doing too much, or you just ask them how they're doing. Explaining the procedures ahead of time and throughout. And the more confident you are and the less terrified you look, then the more confident your patient will be in allowing you to do passive range of motion. So it's a trust, like a trust fall, okay? For some of these individuals that definitely have a lot of pain. Just remember, even if it's just a little bit of motion, a little bit of motion can be eventually into much more range of motion. So even if it's just a little bit, you got to start somewhere. So always remember that, because some patients will be like, I'm just never going to get it. I'm never going to get that range of motion that I need. So if you just work on it a little bit at a time and keep consistent with it, then over time it'll get better, hopefully. Obviously it's best to be done in a gravity eliminated or gravity minimized position, usually in supine, which that's not really technically a gravity minimized position, but that's going to be the most comfortable position, more than likely, for your patient. Unless they can't tolerate supine, then you're going to have to be a little bit strategic there. So like I said, for the patient preparation, you're going to describe the intervention and to meet the set goals. So it's always very important that you go back to the evaluation, you go back to the examination, also looking at the goals in the plan of care. That way you're addressing exactly what you need to in that time frame. You need to be aware of the protocols involved, or if any kind of restrictions of motion, any kind of MD orders, so all of that, okay? Some other things, I think I've addressed all the other bullet points on this PowerPoint slide, so I'm going to go on. And, we're going to go through this whole technique and application of techniques. It's kind of one of those things, you can describe it, but you got to feel it, okay? And just remember, trying to do smooth, slow motion without that sharp increased pain. Definitely for passive range of motion, it's no active muscle contraction. It's just you taking the motion. Now remember, it can also be the patient doing passive range of motion, but ideally you're going to do passive range of motion first before they ever do passive range of motion by themselves, but it just depends on what's going on. All right, I'm going to kind of go through these because we're going to be doing all of this during lab. All right, so next would be active assisted range of motion and active range of motion. So that's how the order it would go. And I already described what that would look like. But and the other one, not just passive range of motion, but the patient can do self-assisted too. So just keep that in mind. For active range of motion limitations, it will not increase strength and strong muscles of 3+ out of 5 or greater. So just remember that, okay? And active range of motion will not develop coordination outside of the rehabilitation planes of motion. And range of motion should always be instituted one joint above and below an immobilized joint. Obviously for, I know this is out of order, but for active range of motion, you always want to demonstrate it. And you can demonstrate that with using passive range of motion of what that would look like, but you don't have to. You can just say, I want you to try to raise your arm up as far as you can. Let's see where you're at. And then if they can't do that against gravity, put them in a gravity minimized position and see if they can do that range of motion. And by just guarding it, like how you would do like a position on sideline and the gravity minimized position for shoulder flexion and extension, and be there to guard it just in case the arm falls. So I keep on using that upper extremity because that's what we're doing first. But for any of them, any joint motion to any part of the body. And you want to make for sure that they're just, not going up and down like crazy. You want them to have a good smooth motion and look for signs of weakness. And then you're going to see, maybe they can get full range of motion or almost in the first round. And you have them keep on doing the active range of motion until you see signs of fatigue and other muscle compensation. That's when, or if there's sharp pain associated, that's when you need to stop the motion and take a break and see if you can do any more, or maybe that's good enough for that therapy session for that particular motion. So some contraindications for a range of motion. Active range is going to be very similar. You don't want to do anything to disrupt the tissue healing process. Some precautions are acute tears, unhealed fractures, acute surgeries. With this benefits of early controlled motion, you can have decreased pain, increased tissue healing, decreased joint and soft tissue contracture formation, and increased synovial fluid production. So the earlier the better, with a range of motion is what that means, benefits of early controlled motion, because, even if someone is supposed to have their rotator cuff repaired, it's a good example, the more motion that they have before they have the surgery, and they're not just guarding it the whole time and having restrictions in the range of motion, the more range of motion that you have before the surgery, the better off they're going to be for that tissue healing to help to decrease the pain and to have more range of motion in general. So I feel like I've gone through each one, but for passive range of motion, active assisted or active range of motion, you want to make for sure they don't have any restrictive clothing. So like, during the winter time, jackets, it's going to restrict their range of motion. So you want to make for sure that they have clothing that's not going to do so. All right, so like I said, moving segment through pain-free range of motion, repeat smooth and rhythmically about 5 to 10 reps. So it just depends on what your purpose is, but around 5 to 10 reps. So we can talk about that more during lab. All right, we'll talk about PNF patterns too. So range of motion as well should not be done when the patient's response or condition is life-threatening. That's just common sense, right? So, but it's on there. And so examination, evaluation, and treatment planning, so determining the appropriate level of range of motion. Need to know what the same amount of motion would be, so that way you're not disrupting the healing process and causing more pain, doing more harm than good. Definitely monitoring response throughout the session from the range of motion, and document and communicate their findings, and reevaluate and modify as appropriate. So just to reiterate, but the techniques to transition from passive range of motion to active assisted range of motion to active range of motion, and all the impacts of gravity and positioning. And so you need to know how to modify accordingly. So these are all the different ones that we're going to go through, and you can go through in your textbook of what are some examples of self-assisted range of motion or active assisted range of motion too. All of that kind of goes hand in hand with one another. Here's some pictures of the CPM, continued passive range of motion. That's considered a mechanical device that moves the joint slowly and continuously through a preset or controlled range of motion. So you as the PTA would be responsible of setting up the CPM correctly and following the MD orders of how to progress. I think this is a great topic to look up on CPGs, because there's a lot of physicians that still utilize CPMs, maybe CPMs too much, while others have gotten away from it altogether and said that it's more beneficial just to have normal range of motion, active assisted range of motion, and passive range of motion, and gait training, and more functional training involved in decreasing the likelihood of a blood clot, the more that they're up. But you'll see CPM still for the knee, like with total knee replacement especially. That's what you're going to see. And here's all the different benefits for that too, for a CPM that you can look over. Okay. And here's all the general guidelines for that too. So like I said, you're going to determine the rate and how much range of motion and how often. Well, really the physician's going to say how often. And usually it'll say like BID, like 2 times a day. It might like say for total knee replacement, for the right knee, do 4 hours BID. So that might be morning and late afternoon, but it just depends on what the MD order would be. All right, so range of motion through functional patterns. So anytime that we can incorporate ADLs or any kind of functioning exercises to improve range of motion, then we're kind of killing 2 birds with 1 stone, so to speak. What kind of activities? Well, obviously you're going to ask what kind of activities that they're having difficulty with. Some other things would be like to look over the outcome measures, for upper extremity functional scale would be an outcome measure for the upper extremity. There's oswestry for low back. There's less for lower extremity. So those are great outcome measures that would be very beneficial to see what kind of activities. But just asking them, and that builds a great subjective